Good morning all. So I'll be discussing performing ultra-thin DSEK in all cases and how it is transforming the outcomes of endothelial keratoplasty in complicated cases. So just to go a little in the history, before 1990s, the only treatment even for endothelial disorders was full thickness penetrating keratoplasty. Then around 98 came PLK or DLEK, where posterior stroma and DM of the host was removed and replaced with the posterior stroma and DM of the donor. Then around 2000, DSEK was there with a graft of 100-150 microns. The Descemet stripping was done and the posterior stroma and wove. In 2006 later on, DMEK was there. DMEK definitely most elegant surgery. The graft is invisible, vision, you can attain a 6x6 vision unaided, minimal rejection and minimal high order aberrations. When it's done, you can't even make out, after some time that the DMEK has been done. But, it's not complication free, it's a technically challenging, there are high chances of rebubbling and a very good visibility. You need a very neat and clean case for this. So in cases where there is poor corneal visibility, hazy corneas with aphakia, deep set eyes, corneas with distorted anatomies, peripheral anterior synecdoche in a old DSEK, or even failed optical grafts. These cases become a challenge for doing a DMEK. Why we want to do DMEK is because it has minimal rejection. So thinner the graft, it is always better to attain thin grafts. So around 2010 by Busin, a surgery known as ultra-thin DSEK was described, where the graft by the definition was less than 100 microns. Actually, we needed something for complicated cases was a balance between, something giving a good visual outcome as compared to DMEK, as well as less technically challenging. So by definition, it is any graft less than 100 microns. I keep a target around 30 to 80 microns. Now they label it as nano-thin DSEK also, because thinner the graft, the faster rehab and better contrast sensitivity. In this, you can see this is just 17 microns, as close to DMEK, where this is a standard DSEK where the graft is around 129 microns. So why do we need? It has a broader applicability, just like DSEK in all complex anterior segment pathologies. The visual outcome is close to DMEK. There are lesser complications as compared to DMEK and lesser rejection rates when compared to a DSEK surgery. And for surgeons who are transitioning from DSEK to DMEK, this is a very good option because the graft behaves similar to DMEK in many ways. You can learn the handling and it's easy to manipulate. So there is less tissue wastage. So this is a DMEK case. This is a ultra-thin DSEK. Only the shadow is visible of the graft and it's a standard DSEK case. So this is how I prepare a graft of a DSEK surgery. Like any other DSEK surgery, I use a 400 micron blade. Then I do a lamellar dissection. After doing the lamellar dissection, just lift the upper cap, keep a hinge. After this, what I start is deepening the groove with a simple side put. I just deepen it sufficient. It's just by ideas. Once you keep doing it, you start getting an idea. Then I use a cyclodialysis spatula. No other instruments in my hand at least work, and start transforming the rim. This surgery technique was described by Dr. Santosh Suman and also modified by Dr. Fogla. Then you just peel it and you get a very smooth graft. There is no problem, and if it is peeling very easily, it means that we are in the deeper layers. If you do struggle in peeling, it means the layers are superficial, still superficial. So we get a very smooth interface. And these grafts, then we do the stamping. It's very important to stamp these grafts because if you don't stamp, you can't make out sometimes if it's inverted. So for a successful results in these surgeries, it's very important that we put a good stamp or any asymmetric mark. Busin glide or even DMEK injector is useful. AC maintainer helps us put these grafts. And if you get a very thin graft, the manipulation is same as DMEK. The only benefit is that you can pull it with a micro forceps, so it's easy as compared to DMEK graft. So this is, I'm showing a video of a case where, I got a very thin graft and I treated it just like a DMEK and inserted also through. This was the case where it was a repeat DSEK with peripheral anterior synecdoche. So in the same way as a DMEK is done, I insert this graft through an injector. So these grafts are thin and we deal them in all ways, trying to do a no-touch technique. So it boosts the confidence already of a surgeon who's doing DSEK, because we know how to handle a DSEK graft, we know how to pull it, from the periphery if it goes to side. Then the maneuvers also, it behaves the same way. Just by tapping, it opens up. And the best part is it opens up easily because there is a stroma, so there is not too much tight coiling. So once we are comfortable with the movement, we just inflate and we get a very good apposition. So the best part of these surgeries is in challenging cases. So because there is a poor visibility, anatomies are distorted and the ACs is deep. So we need obviously something which can be manipulated without damaging tissue and less complicated. And moreover, the stroma stains more than the DM alone. So you can, you need more visibility in these cases. So this is a case where there was poor corneal visibility, PL vision, hypertrophied epithelium from long standing. The ultra thin DSEK was done. The graft is 17 microns. You see the patient was around 636 and the picture is just 2 weeks later. The graft attained clarity very well. This patient came with a presumed dead eye and he had an infection. The infection was treated. He had an aphakia, bad aphakia, long standing 10 years. I counseled him that, we should make it some useful because there is a visual potential behind. So we did an SFIOL. This image shows that there was some, inverted, the graft was initially inverted. Again, it was re-inverted. This is aphakic. This is with SFIOL. And we got a very thin graft and the patient is 624 and he's very happy. So a post-PK failed graft, ultra thin DSEK was done with a graft thickness just 23 microns and best corrected vision in this case is 6/9. So this is the case which video I showed. This has all peripheral anterior syneci. The syneci were released and after that, ultra thin DSEK was done. Only the peripheral ledge is here visible. Rest you can't even make out where the graft is. Obviously, it is not complication free. As compared to DSEK, there is chances. Now, this is the case, that infected case. I got an inverted graft initially. So, it was, re-inverted because this U, like a DMEC, is on the inner side. So, this is the stromal side. So, I re-inverted it, applied it, and the patient is doing great. Obviously, with too much handling, there are chances that you fail the graft. So the take-home message is that we should aim for ultra-thin DSEK in all cases. It is reproducible and effective. The results are consistent if you have good donor preparation and gentle insertion. Very useful in anterior segment pathologies. For surgeons transitioning to DMEC, it acts as a bridge between DSEK and DMEC. So I would say it's just not a compromise, it's a transformative surgery. Thank you.
Thank you, sir, for the wonderful talk. I think you are doing the manual preparation for the
Yeah, I do manual preparation.
So the issue will be the unevenness of the thickness of the graft.
So it doesn't get uneven because we do peel and dissect. Once you peel and dissect, you always, if the posterior stromal layers, you are there. So the stromal, the peeling is always in the same plane. Peeling never goes in a different plane. It is only when we do the lamellar dissections that the planes tend to change. Like in DELC also, initially this technique was for DELC that Dr. Rishi Swarup used to do, that you peel and dissect. So once we peel it, there are very less chances that you are going to be in a different plane.
And when you are deepening with the side port, the second part,
yes.
So any chances of perforation at that time?
Yes, there are chances of perforation. That is what I say, if it is even a small perforation, it is not going to bother you because you can change the site. The perforation, when we do it very carefully under a high magnification on the side port, you will see after some time you will make out. Moreover, as all we do DSEK, we know when we are using a 350 or 400 micron, we know that around somewhere between 300 to 400, we have already sacrificed the tissue. So even a single stroke in the beginning will give you a tissue deeper than what you usually do. If you are getting a routine graft of say 150 microns, even a one single stroke for a beginning will give you around 125 microns. The next time you do it more, and after some time actually you start getting an idea that 2-3 strokes is going to take me where I want to go.
I think the results are same, whether you take 70, 80 or 100, results are same.
After some time, say 6-8 months, we all have seen that the graft, it constricts a little. If it's initially 150, it becomes 130.
130, 120.
So once it is less than 80 microns, you are not going to make it after 6 months. This is what, in my limited experience, I've seen.
Any questions from the audience?
Thank you.
Just similar comment to the ulcer. No, I don't know, but in my practice, most of the patients, they present quite late. DSEK is a very wonderful procedure when we do it. The problem is sometimes these patients, these corneas, they have irreversible haze in the interior part. And then फिर आपको लगता है यार better we could have done a PKP. The graft is sticking, cornea is not clear. Patient has subnormal vision. It happens quite often. So it's not like Western countries where you have fixed dystrophy and you know the nearly virgin
Exactly,
cornea.
sir.
Our practice patient even PBK fix is almost non-existent in Punjab. I hardly see like 1 or 2 cases in a year. So most of our cases are PVK. And these patients, when they have like 620, 624, 618 vision, they are not going to get operated. And once they drop it, by that time there is irreversible scarring in the subepithelium stroma and usually it doesn't clear up. That's my observation that some of these patients which we end up doing DSEK might better benefit from the PKP. At least you have a clear visual axis. So whether we are over killing it or not, that's one aspect to it. I don't know what they do in LVP.
I think you are overkilling it because the PK part is difficult to patient will not be able to maintain it because they have 16 sutures. So 1 year to will have suture related issues and the most important thing is the rejection. PK graft can reject at any time. If you see the rejection rate between the PK and the DSEK, PK has 30% rejection rate and the DSEK has less than 10%. So even if they have minimum scarring or you can say moderate scarring, I will do DSEK. Because I have seen multiple cases over the time that scarring also reduces.
Reduces, yes sir.
You will get 618, 612. That is better than getting into the rejection and then doing the repeat PK, then again rejection and then completely HM plus.
My point was most of the cases we end up doing DSEK, they never attain 6/6, most of.
That is not required.
So
I think 618 is enough.
No, PKP, if you clear graft, you put in RGP, you will get a 6/6, many of these
Sir,
cases.
even in, I
That-
would differ. No,
Second, point I am making is many of these patients, the scarring, it doesn't go away.
sir,
आपकी cases जो 5-7 साल होने शुरू हो
नहीं,
जाएंगे,
sir,
then you will realize that
I would differ a little in this that even in DSEK cases, if you put RGP, you will get a 6/6 vision, sir. You don't need a PK for putting an RGP because if you do a DSEK patient where the vision is 6 or these scarred cases which I showed, these were all like, these cases, you know, the cases I showed, they had that scar. I tell them one thing, sir. First of all, their presentation is so late. I teach them that, see, this eye is going to be like a Stepney. God forbid something happens to your good eye, you are standing nowhere. So we just prepare them for then, you know, for the worst times. Second thing, I agree with sir, because PK, because a patient who reached so late is never going to come for even after a PK very quickly. You know, once they are fine, they'll go home. Then there is a loose suture with total rejection, and then you see what we've done. So for me, 618, 624 from PL or somebody who's presuming that his eye was dead is like a good, they are happy even that because they are seeing the peripheral side from at one time, which I was not given even peripheral vision, nor they even getting 624 is, you know, somebody with a PL is good. It's, I think, us, you know, looking the graft every time seeing, yaar, isse clear ho sakta tha. So that's, I think, yes, sir. Yeah, they don't get it, sir. Expensive lenses, they say कि बहुत महंगा है.
Yeah, they will not wear it. They will not use it.
I used to consult for 5 years, that it worked for 5 years. Less rate. Now I started saying 8-10 साल चलेगा. Then some buy because their validity in our part of this, you know, they want कि 10 साल तक चल जाए फिर पैसा वसूल है. So, हाँ, that's everybody of us knows this. Because lamellar surgeries, obviously they've changed the game. They are minimal for rejections and suture related. And I think
no, that point is how to have that patient come to us early and consult, then he is 612 or 618, that this cornea is going to decompensate. That is the challenge.
You have to explain the disadvantages of PK. No, you have to explain him the disadvantages of PK. That it will reject, it can fail.
But I would say ultra thin DSEK or DMAC, they give you 6669.
The aim in corneal transplantation is graft survival, not the vision, I think.
Exactly.
Whether your graft will survive or not, that is the main aim. Vision is secondary.
Sir, but with this advent of DMAC, right now, maybe 5 years later, when we'll be very comfortable, 6.6 is going to be a norm. In, once the referring surgeons start getting confidence, so I always share those DMAC cases with them. When they see a case 6/6, which they operated, उनका भी हौसला खुल जाता है कि PB के हो भी गई, they can refer very easily. And patient को पता भी नहीं चलता, I get some surgeons जिनका हो जाता है, they send, we do it, patients अच्छे हैं, तो everything is fine. Patient को just like a nucleus drop पता ही नहीं चलता कि कुछ हुआ भी था मेरे साथ. So it's going to be the next thing for us. So that's why this technique by Dr. Santosh Suman, Doctor, that happens when we are dissecting the second plane. I showed the peel and dissect thing. In peel and dissect, I can assure you, once you lift it up and you see it's dissecting very easily, you were not going to get a perforation. That is for sure. Even in my DEL cases, I get a smooth plane because the moment I go, the posterior layers are very loosely compact as compared to anterior. Once you are posterior, you just dissect it, they'll remove very easily. So just try this and you are going to see. And this is again one good thing about ultra thin DSEK as compared to DMAC, that young tissues you can't do a DMAC, the scroll is very tight. But for ultra thin DSEK, you get a very good plane. But one thing for young tissues, what I say is don't go with the 400 microns. Their tissues are very compact. Go with the 350 microns, because whatever you do regularly in a aged cases, when you do the same thing in a young tissue, they are slightly compact. So अगर आपका routine में 150 120 DSEK में आ रहा है, तो उसमें आपका 80 अपने आप ही आ जाएगा. They go very very thin, even with a standard normal DSEK with a single plane pass. Ma'am, I try to keep it above 24-2500. Sir, in scar, femto doesn't work well when there is a scarring. But yes, sir, first pass we can do. There are people who are doing rather than a microkeratome. If we want to prepare a DSEK, a decimal stripping automated endothelial keratoplasty, first cap can be lifted with the femto, and second again you can do with the femto, sir. That is possible, sir. This is, I think, somebody might be doing, but still they are doing it. The problem only is, sir, with microkeratome we can get a through and through thickness. Whereas in femto, you define the area. We can't go too much in the periphery. When we have to punch, we need a tissue which is exactly the same size. Because the inner side, we have to punch it, sir.
Do you think that there should be a certain thickness of the DSEK graft, or beyond that, you think the survival goes down?
Yes, 150, something above 200 is not going to clear. You are asking the maximum thickness or the minimum? Maximum thickness, I would say, is like 150 microns is a very good thickness. Those grafts work very well. Between 150 200, they take very long time to clear out. The patient will be free of symptoms, as Dr. Akash said, but visual clarity will not be there because there is too much of stroma now, and there are very high chances they are going to get past peripheral anterior synecdoche over long time. Thicker the graft, the higher chances of peripheral anterior synecdoches in those cases. Ma'am, I make a SICS tunnel for routine cases, but with ultra thin DSEK, Busin glide, because when I started doing it with a tunnel. They are so thin, because the chamber suddenly collapsed, the graft comes out and it's become a problem. So, Busin glide, 3 mm graft, DMAC injector, this is very good with this.
How fragile are these grafts, like while handling it?
Sir, they are fragile, but they are not as fragile as DMAC.
That is definitely because...
So you can hold the periphery with a microforceps.
Okay.
You can pull it. Sometimes it happens, I try doing maneuvers. If it doesn't work, the best thing is just like a DSEK graft, hold the periphery, the microforceps, bring it in the center, you pull it. Even if you are using with a Busin glide, if the AC maintainer is on the other side, you pull it from this side, it is like a DMAC, it is not going to collapse. It is going to stay the same way. So stop the AC maintainer, put air, it will spread. And once it's there, you can even unroll it with the reverse Simsky. It gets, that's the beauty, you know. You can play with it without losing the tissue, try your DMEC maneuvers, and then you can just put the graft if you get tired or you see that it's being too much.
We have to open it with air only. You're opening with it air only, the ultra thin graft?
Yes,
Pushing
yes, sir.
only air?
Yeah, simple air only.
Okay.
You don't need to, you know, unroll it with your hands. What is the other option, sir, you are asking? I mean, without air, I mean, how do we open it?
Like we open the DMEC graft now, we're tapping it.
Yeah, no, sir. You open it that way also.
Or only
इसमें
tapping
ऐसे
only.
क्या था?
Because I have not done ultra thin. I have done maximum 100, not less than 100. So I don't know the experience with how fragile they will be, whether they will like scroll like the DMEC graft or not.
They scroll it, sir.
They
You
scroll.
see, they scroll.
Okay.
The only good part is they don't scroll too tight.
Too tight like DMEC.
They scroll.
Fine.
जो ये केस भी था सर, it was scrolled. That's why using glide से better यही था कि to put it with a DMEC injection.
Yeah. Thank you.